I know. Okay, we're gonna go ahead and get started. Okay, I just want to thank everyone for being here today. I really appreciate your time this lunch hour, but I think we're really going to be blessed with the time we spent here. So it's great honor to introduce Dr. Terry Maresca, a board-certified family physician and educator, an advocate whose work beautifully bridges Western medicine and Indigenous healing traditions. Dr. Maresca is a proud member of the Mohawk Nation from Kahnawake and devoted more than 3 decades to caring for Native, Indigenous, and underserved communities. She serves as a clinical professor of family medicine at the University of Washington School of Medicine, where she mentors the next generation of Indigenous physicians and health leaders. Her practice and teaching weave together modern science and ancestral knowledge, embracing plant medicine, seed saving, land stewardship, and holistic approaches to health and healing. Through this integrative lens, she reminds us that true wellness is rooted in relationships with our bodies, our communities, and the earth itself. Dr. Maresca has been recognized nationally for her leadership in Indigenous health, medical education, and food sovereignty, and for her vision of medicine that honors both culture and science. Please join me in welcoming an inspiring leader, educator, and bridge builder, Dr. Terry Maresca.
So now Dr. Holika, Sego Sebuego, Terry Maresca Isaiah, Ganika Hagani Wakinu, Tanu Wakingata. What Kunuwerado was what we would say in our language. Dewanuwerado means to all of you. And that's my thanks to all of the traditional people of this territory where we're standing now, to all of the Indigenous peoples in Montana, including our urban natives as well. It's an honor to be back. It's an honor to be here in the beautiful fall season. So my respect, my greetings. What a great quick tour I just had out in the plant gardens. I'm like, yes, I spent a week. We should all go out there. That's the medicine is out there. So my thanks to you. My thanks to the Native Center of Excellence for this invitation. You know what? To Brittany Hunter again, to Dr. Holub for inviting me. I've got objectives because I guess we're in kind of like a little bit of Western mode, sort of right now. So I thought I have a couple of them, and it'll be a little different than for those of you who might be joining us later this afternoon for a little more hands-on type of work. But I wanted to make sure that we understood, even in a tiniest sense, what the core underpinnings are related to the legal relationship with health and why plant medicine is a significant treatment option for our people in Indian country. And also a little bit about just some of the reasons why plant medicine should be discussed and maybe why sometimes it's hard to discuss within a clinical encounter. A couple of cases just to really briefly illustrate some of the clinical applications of this, what it looks like on my side of the house when I'm seeing people in a clinic or a hospital setting. And then I just food for thought at the end, which we won't be discussing too much, but what is the relationship with Indigenous knowledge holders within the community? Because that's where that knowledge has continued to live and will continue to live. And so it's so as good as our systems are in academia, there is a whole different system that is much more longer standing in terms of Indigenous knowledge. I wanted to start off, I just came back from a trip to my home territory is south of Montreal. And I did a trip just a few weeks ago into maritime Canada. And one of my missions with this is that I'd heard stories from my elders in Mohawk territory about the coming of visitors that came up the St. Lawrence River. And that person happened to be Jacques Cartier in 1535. And our people tell a story, and so do the Wendat Nation, some people you may know as the Huron Nation, shared the same story, that when these visitors came, they basically camped, and they camped outside of Quebec City. And I always wondered where that was, and I always wondered if that was for real. And what the story was that they were very sick. Those people on the ship were really ill. And they were ill with scurvy, which was a very common thing with these long sea voyages. And our people felt sorry for them. Just the ongwe, the human nature of this, saw them suffering and treated them. We treated them with medicine that came from a tree. And to my amazement, when I went there for the first time, I didn't know that a place existed that actually documented where Jacques Cartier actually was. But I stumbled upon it, which is kind of the beautiful work of spirit, I think, sometimes takes you to where you may need that lesson. And so there it was, and there was an actual drawing of what was happening with the crew who understood then how to make it after being taught, and they called it Aneda. So there's a long-standing documentation even at the point of contact, and not to forget the fact that we also had relatives in Central America with their amazing codices from the Aztec and Maya people who were writers and beautiful illustrators who documented their plant medicine. So we know that this goes back a long, long way. But I love this, maybe just because my tribe was involved in that, it is possible. But I think it's one of the first documented elements of where that medicine was being utilized, that people were interacting in that way. Objective one, where does this all what's the relationship here? So Indigenous health has to do as a piece of treaty rights. And those treaty rights that were really codified in the late 1700s after the US became the US after 1776. Our native tribes have a legal status with the government. And some of what we gave up as a people in terms of our territory, some of our resources, had to do with some reciprocity as the right to access health, and the way that we wanted to be able to do that. So the right to health is treaty bound. It has nothing to do with ethnicity or race or finances. It has to do with treaty rights. And that same government then, in terms of just, we're fast forward 100 years later or so, that some of those practices related to indigenous medicine, which includes also medicine people working in spiritual realms, working in other realms, was actually abolished. I mean, so there were people were punished, people died who were practicing plant medicine, who were practicing indigenous medicine, what I would call our traditional medicines. And I was in college in 1978 when that got restored legally. So this is in my lifetime I've lived to see that restoration of this. So that's not, and there's more. So the issues of what the other pieces of why this is important within our communities is because the structure of what some of you may know as Indian Health Services, IHS, has three parts to it. And there's a federal part in terms of tribes that are still working directly with the federal government. For example, Absalage, just out in Crow territory, has that relationship. Versus myself working for Seattle Indian Health Board as an urban program versus tribal program down at Puyallup Tribal Territory. So some of our tribes here up in Polson, Ronan area with Confederated Salish Kootenai are in a tribal situation. But all of these systems also have laws that they must abide by in terms of what's providing the best care to people. And it turns out that about 30 years ago, they also made that part of the policy of Indian Health Service, that our job was to be able to facilitate people's right to access medicine the way that they needed that, according to tribal customs, whatever those customs were. So whatever those practices were, those of us working in these systems had to work to be able to make that happen. And that's also one of the hardest things, I think, for people who are newcomers to our system, is understanding that. Because traditional medicine, this is a definition of traditional medicine from the World Health Organization. And the piece that I highlighted has to do with whether we can explain it or not with whatever your mindset is coming into this. Your own cultural lens, the lens of Western medicine, which has tremendous validity, but is also a different level of evidence-based medicine and practice. So however you think of it, when faced with indigenous practices, the tie goes to the runner is always going to be the traditional practice in terms of our ability to work with that, and how can we do that respectfully and safely. So this is what I think is going through the minds of a lot of us in terms of, because sometimes we wear other hats because of our life experiences, in terms of, is this based in just the practice where I'm at, that this works in my particular unique setting? Is this evidence-based practice that has randomized double-blind placebo-controlled trials, that are really important and valid, to be able to come to a conclusion? And or is this traditional cultural knowledge that goes back thousands of years that has been tested in those settings? And sometimes there's tension there, but I believe there's also reciprocity that really could exist between these. And so the topic I think is pertinent. Our medicines have survived colonization. They have been around. It's not a thing of the past. I hear herbal people talk about, oh, well, such and such community used to do that. No, my friends, they still do that. So it depends on people's life experience with those medicines. And some of us have very specific, probably, I don't know, I can't say for everyone, but I know for our tribal communities, the issues of relationship to plant is part of what Haudenosaunee people, what we think of as our original teachings. When you came to this life on this earth mother, there are core relationships that we have with medicine. And I'm sort of wearing our representation of that today, which is our strawberry. So our culture teaches that Gantnio which is our strawberry, represents all medicine in the world. That's what's happening here. That's what happens when we're in a pharmacy. That's what happens when I pick a plant. That's what happens when you smile at somebody and you give them some of your joy. All medicine relates to that. So some of us have those teachings and those continue. It's obvious that some medicines are still, they're effective. And people who practice that way are held in high regard in our communities. So that's a thing. And the reclamation of that, because for some communities, especially some of the smaller ones who've experienced a lot more trauma, may be borrowing from other communities that were, similar language speaking groups or in the urban setting. That presents its own beauty and challenge too. But that this has positive impact on people spiritually and physically to be able to do that reclamation. I think it's quite obvious also that a lot of our plants are under duress, lots of them. Our waterways, our lands in terms of issues of contamination. The Dakotas, some of the Dakota tribes in North Dakota had to put out specific laws to prohibit people from just poaching echinacea, just as an example. Just like the fact that they had to put that into law, just is super striking, and as well as just the territorial challenges with plants like ginseng. But I think for many of us who are in the field here, for maybe most of you who are working within pharmacy, there was a person out at Harvard, I heard him speak, and he said something that has really stuck with me. He's like, this issue of our cultural medicines and pharmaceutical science is the grand experiment. This has been happening, for maybe more so in the last 100 years, as we have more and more pharmaceuticals available to us with incredible potency. And we still have our various traditions, indigenous and non-indigenous traditions, that some of how this works together, we don't, when we're looking at it from a biologic standpoint for safety, we don't always know what that answer is, how that's really going to work. And that comes up a lot in clinical practice. The other piece that comes up a lot has to do with the issues of advice. You as pharmacy people, if any of you in the room are nurses, you are seen as really high regard people that are trusted people. You've earned that. You're working to earn that right. And that's a really important position to be in. What has been fascinating to me, because I work in residency training programs, so I'm working with young physicians all the time. And what I think hurts their heart sometimes is that, hey, Terry, I saw this person and it turns out they went to see one of the healers and basically they didn't do anything that I said. I'm thinking, okay, and in that case, the healer's advice was more pertinent to their situation than yours. And there is some data to support that. A very interesting study from a couple of decades ago that was done in Milwaukee really looked at this in terms of just, first of all, did you even trust your clinic? These were people who were being seen in an urban clinic from multiple tribes. And so they could have access to both herbal people, spiritual healers, as well as doctors, physician assistants, etc. And they didn't tell their own doctor what they were doing the majority of the time. There was just this issue of trust is a real thing, and it's earned, and it takes time to be able to develop that. This is one of my dotas. She's my elder from Six Nations, so a beloved plant person to me. But again, when Grandma Jan speaks, everybody's listening. Just like that's some of that is just like the law that that traditional cultural knowledge that's passed down. Just to point out, I know we have a beautiful urban clinic right here in our own backyard with here in Missoula. But just as a reminder that urbans are also using plant medicine too. and other forms of traditional healing. And we have some small studies from different parts of the country corroborating that. And the percentages may vary, but it's not zero. And so again, whether or not we're being told that, or that's being shared in an encounter, becomes part of our work as clinical people to develop that relationship. So it's out there, it's still happening. And there are certain factors that are, I'll call it demographic, maybe that's not totally the right word, but that are associated with more plant use. And as a doctor, I listen for that really, really carefully. Some of them will make sense to you. Some, people who are older, so people like myself who've got gray hair, who may have Medicare, probably higher likelihood with that. And some of that, unfortunately, may have to do with issues of chronic illness. So if someone has a chronic disease, they may be more likely to be looking for other options for their care. That's also true for people who are experiencing behavioral health challenges. That also includes addiction disorders, more likelihood there. If someone speaks their language or even really trying to reclaim their language, higher rates of use. People who are going back and forth, maybe in an urban setting and going home to a reservation or reserved territory, higher likelihood of use. Unfortunately, also a pain diagnosis for whatever that painful condition may be. Maybe it's arthritis, maybe it's something, something else. So we know that to be true. And a piece that's not on there that it hasn't been reported in journals, but I see in my own practice is skin disorder. So there's higher rates of atopic disease in American Indian communities. And so I see a lot more young children, as well as older adults who have the spectrum of the allergic spectrum that relates to eczema, to asthma, to, maybe to other autoimmune associated diseases. And so issues of skin problems is what I see as a clinician that we often get asked to intervene with medicine. So I thought I'd do a little comparison before we go into cases of like, where do we see this in the community? Because some of my students ask that, well, you say it's out there, Tara, but where is it? But okay. Well, some of it's a little more hidden unless you are a person who has relationship within the tribal community. So what I call our tribal doctors, so we may say our medicine people have different terms for if they're working strictly with plants or with other things, but they're in the community and there are people who are specialists, just like some of you are, in terms of the work that you do. And so getting to know who those people are is often an issue of word of mouth. We're not seeing ads related to this or out in the social media scene so much. This is something people who are known in the community. Some of us are fortunate that we are working within tribal practices or urban practices where there's a traditional health department, where there are people who have plant expertise that are there. So that someone like myself, if I'm coming in as a relative, as a patient, that I could make a choice. I might want to go see traditional health, and I might still want to see my nurse practitioner. So some of us have departments where that becomes an access point. It's been long understood, and I think probably one of the other prototypes that's been going on for a while for those either tribally controlled or private sector chemical dependency treatment centers. If someone's in treatment, many of the options that are being given for people who are dealing with some challenges within treatment in terms of the detox process are using indigenous medicine for a lot of our programs, which is really important to know if you're working, within those communities. And something less common, but we are fortunate to have one in Western Washington, our cancer centers who really have a specific public focus to say that if you are interested in alternatives for your cancer treatment, you want to be incorporating cultural practices, plant medicine practices, other practices, you can do so. And so we're seeing that at the Salish Cancer Center, which is near Tacoma, Washington. I don't think that's super common though, but we are seeing that. We're seeing it in midwifery. So again, not every place has doulas, has indigenous midwives. Midwives have been on this for a long time in terms of just what helps to support pregnancy, birth, breastfeeding processes. But a lot of it is also just transmitted through culture. It's just transmitted as just part of who we are. I see this more with what I call rites of passage, at least within my tribal territory, with young people who are teenagers who are becoming young men, young women. And some of those teachings have to do with how do you take care of yourself as an adult? So some of that plant medicine teaching has to do with take care of your body, and also the preparation for, do you know some of the basics to be able to take care of a family someday? So some of it is what I call, again, grandparent teachings. Your aunties, your uncles, what do you need to know to be able to raise a good family and to take care of yourself generally? But we also see some of this with larger community settings, and some of you may be familiar with what's called the canoe journeys in the summer. That's happening over in Western Washington. It's mostly Coast Salish tribes. And so the thousands of people really are participating in this in terms of canoe gatherings with a host nation at the end of a long journey, either on the Canadian side or the US side. And many of those canoe families have done the preparation to take care of themselves for the rigors of that journey with plant medicine. So they're going with their medicine kits. So that part of their work the year before is making the medicine kits for taking care of, again, sunburn or rashes or, stomach issues or whatever they need. And when those communities gather in the host nation, there's also two options for them. So they have what I'll call like the tents that are the regular medical tents. And then they've got the spiritual and plant medicine tents for people who may need to be doctored that way. So we see it in community. I see it in indigenous businesses that are people who are plant people who are experts who have chosen to provide some of that medicine out to the community for people who don't have access. And so that is how it's visible, but it's also visible sort of it's in our house, it's in our homes. So if you walked in my house right now, there's things that look like leafy things everywhere so it's just the final harvest before the frost. So lots of things are drying, within the home right now. And again, with our kids. So this is my nephew, when I took him home, and he is vigorously palpating a staghorn sumac because he thought it was fuzzy and delicious, and just how we engage our young people in our lands and our teachings. What does it look like in Western settings? Some of you already know this. Again, for some of you may not have had the beautiful experience of this, but in our clinic in Seattle, which serves over 200 different tribal nations at Seattle Indian Health Board, we actually have an herbal formulary on our staff. So we have a regular pharmaceutical formulary. We have a separate herbal formulary that's quite small. Can I tell you, it took us over 15 years to get there for a lot of reasons. But some places do have that, and again, just depending on your level of practice and experience, you can choose to prescribe, just like you can choose to prescribe from the regular formulary. There are medicine people who could be contracted within a clinic. So someone who's on staff, again, that's also true within our setting, for the both places that I work, that there is a department where we can refer people with more expertise to work with our people. Some clinics have chosen to have a different type of practitioner within their settings, what I call the pickers. This is up in Michigan, where a healer may make a diagnosis with someone who needs plant medicine, and the person who needs to be doctored doesn't pick their own in this case. So they're trusting what we call the picker, people who know the protocols, who know where it's safe to go to get the medicines, but they're not the ones telling them how to use that. They're healers telling them that, but the pickers are able to do that safely. So we see models for that. Again, I don't think that's super common, but it does exist. Many places have medicinal gardens to be able to emphasize this, this option, for people to choose either way. And I see this in the community in terms of with tribal colleges that have offered courses. I've always invited health people to join them, to be able to learn what may be local from local experts. Some of that may also be other Native nonprofit organizations that are working in indigenous food restoration or plants. So it's in our health settings, and it's also in hospital settings sometimes too, and that's not in a formulary sense, at least not from what I've seen. But sometimes we, I guess just being in Seattle, we're getting a fair number of people who from trauma or other complex cases coming in through Harborview, and maybe coming in from Alaska, some are coming in from Montana. And so some of our team gets requests because there are tribal people who are suddenly in the situation of being in Seattle and not with the medicines that they may need to be dealing with a very difficult situation. These are usually people who are in the ICU. It's either something happening in the ER or some aftermath of a situation that they need access to certain medicines that because it was so acute, they didn't have time to necessarily prepare for that. So some of our team works with them to be able to if we have that medicine, to provide it for them to do what they need to do to take care of their loved one. in those difficult situations. And at least for University of Washington and our training program in Seattle, and I see this also in Puyallup, we're trying to work with our young people, with multicultural young people, our Native kids, our other youth who are interested in this way, to be able to uplift them, and also trying to make this clinically relevant for the people that they serve. So Dr. Ornelas is over on our right, and so we're essentially working with him one-on-one in terms of just plant medicine that's pertinent to his tribe over in Umatilla. So some of us have programs where we're actually trying to mentor people to have a better understanding. That doesn't mean they're going to be full practitioners, but they're safer practitioners, and that's what our community wants, people who are respectful and safe. So pros and cons, we can imagine some of the pros and cons of asking people about this. Clearly, it shows respect for someone's worldview when you're asking about whether or not someone is using the medicines. And I think it helps the partnership over the long haul. Recognizing again, some of the medicine choices might be more effective than what may be on a formulary, or as effective, and it may be more accessible, especially financially. I see that in the urban setting a lot in terms of people's need for access to medicines. Some people are more afraid of issues of side effects, and again, it's not to say that plant medicine doesn't have them, they do, and they can be very potent. So the issue may be a person's judgment call in terms of what they think is safer for them. So I think that the disclosure when we're working with people clinically has to do with how can we minimize adverse drug reactions? Could I anticipate something? Could I make the treatment plan safer if someone's choosing to use a medicine that I think may have an interaction, or I know is going to have an interaction, then how do I introduce that topic? On the other side, there's also cons to that, depending on how you ask. And some of it is just assumptions of not everybody uses that, as Native people, or want that. Just like that's not something that a lot of people are like, no, I'd rather, whatever, get the antibiotic, Terry. Okay. Sometimes it can be upsetting to a person if they're not understanding where you're going with this line of questioning. They think you're nosy. They think you're trying to appropriate something. We don't want that attitude there. So a lot of fear about how the information is going to get used. Is this in my chart? How might this be? How is this going to get? Whatever the documentation piece makes people uncomfortable. So how does it show up in a primary care setting, right? And so I thought we'd just talk about a couple of maybe just short scenarios of just like what happens. And I love our residents because they were always bringing me fun things about things that happened, to them. So they're seeing the patients and then they talk to me and it's just like, Terry, I hit a wall. I don't know what to do with that. And honestly, that is music to my ears when I hear that, because that humility really means something. That means it's checking in with yourself. It's keeping it safe. It's realizing there may be other people who have expertise and trying to bring them in. So that humble attitude of, I don't know, and I'm coming to you to try to help me figure that out. That's a beautiful place to be. And we've all been there in terms of as learners. So in this case, there was an elder who came in and she has hypertension. She's coming in for a routine checkup and she's doing a pretty good job. She brings in her numbers. She's got this beautiful little list. Her blood pressure looks terrific. Her blood pressure in clinic looks great. Her exam looks great. And she didn't tell my resident. She told the nurse. So she got all kinds of props for things were going great. And then she told the nurse that, hey, I've been using this plant and I'm eating it. I'm drinking it. I'm eating it. Because I think it's helping my pressure, my blood pressure. And I'm still taking my prescription, but I'm also using this. And so my resident comes in and is like, hey, Terry, have you ever heard of that? It's like, I said, well, does she know what it's called? Is that really a true picture of it? It's like, oh yeah, we know what that is. So here's our stinging nettle. There's actually several different kinds of nettles depending on where you live. So it's common in a lot of the United States. And one of the fun things from a salt standpoint is that it's full of salt. It's just not full of sodium salt. And so we all know that all of the above in terms of these fun double cation substances actually reduce blood pressure by themselves. So it's like, oh, interesting. So these are plants that are high in the salts that are necessary for better cardiac function. So we see this a lot in the Pacific Northwest because there's different teachings related to kind of like spring medicines that wake up your body after being cold and wet and just not having access to clean things, and just like how one might do that to kind of introduce yourself back into that natural world. And so it's a very common springtime medicine for people to be able to eat that in different ways. Lots of ways to prepare that deliciously. And it does indeed have diuretic properties, which could lower your blood pressure and make you pee more. So I have some people who drink it just because they like the taste of it. It's like, Terry, it's the weirdest thing. Like, I'm just peeing a lot. Yeah, you're gonna pee. So maybe you don't drink that big glass of it at night, if that's what's keeping you up at night because you gotta wake up and pee. It also is blood sugar lowering. How much? I mean, it's not like you can get with levels of insulin. It's subtle but present. So someone who's trying to keep blood pressures more regulated might have a benefit from that. There are people who use that for allergy treatment, usually if they're allergic to things that are in that region. So someone on the Western Washington, could potentially use that as a way of treating typical allergic, symptoms. It's rare, but I do see elders who still use that for pain control, which is a very old school way of doing that, just because the stingers, with their little, histamines in them. Also, if you touch your body parts to stay awake, or if you're a hunter, I have my brother is out there right now, coming towards Missoula shortly. He's probably been doing that. He's old school trained, he's actually a Anishinaabe, but he's out hunting, and so he needs to keep himself awake. So if he has access to nettle, which right now, of course, it's cold, he probably doesn't have fresh nettle, but if it was earlier in the season, he probably could use that in terms of just that stings, and I need to stay awake for this important work. But when you do that, it also releases substance P, our friend, our pain, one of our pain medicines that we're trying to reduce. And so someone who's using that regularly could get good pain control, topically. There is some mild uterine contraction activity, and it's fascinating because some of our tribes also use that for women who are pregnant and breastfeeding. And again, there's also traditional cultural knowledge in terms of what allows that to be safer in terms of how that's used. So my resident was like, okay, so it really is a thing, Terry. Okay, I don't know it yet. This person wasn't a plant person. I think they were coming from Chicago. So I said, well, how would you research that? And so now you got the clinical application, looks like she's doing great with her pressure. How do you think about it? And so in this case, they went to NatMed, to the Natural Medicine database. And so I'm not sure if it's here. I assume you do have access to that too. So we have it on our University of Washington Health base. So they basically went and said, oh, well, it says, yeah, it's probably safe. The side effect profile is really pretty low with this. And then the issues of where it's more effective, came to, primarily diabetes. And so I think they were quite surprised to find that. And also I'm not going to give you the whole scenario there, but some of that database was also saying that, yes, that could be used for, for hypertension as well. But the other pieces of this that were pertinent, because she's already taking a second blood pressure, she's on BP meds. So it had to do with this data set, talks about, well, how much is the interaction and what's the data that supports that? And so the data for the diabetes piece, it is randomized controlled trials. They maybe not the best in the universe, but at least it was that style. And then for the diuretics, it's like, well, it's an in vitro thing. It happens in animals. We know at least theoretically that could occur. So then the question was, so now what are you going to do about it? So, and here's the thing too, was like, she didn't tell you, but that nurse has been there for 20 years, who's a very trusted person. So please don't take some of that personally, or at least let's think about that. That was a person who's known them for a long time, who they trust, and they were proud. They were acknowledged for doing so well. It's like, yeah, I'm doing these things to help myself. So what do you do with that clinically? And that's the questions that we talk about in the exam room, or outside the exam room, in terms of how do you work with an alliance with people, because there's some synergy. But in her case, she's not getting orthostatic hypotension. She's actually doing pretty well with it. So it's like, well, what's your vote? Carry on, continue to monitor. She's already doing home BP monitors. She looks great. So that becomes our decision clinically in terms of what do we do with that information. Second person is actually from Alaska, from Puyallup. So it's a Tlingit territory, one of the smaller islands in Southeast. They were up at fish camp. And fish camps, someone showed them how how to collect medicine to be able to control blood sugar. So this is a person who has pre-diabetes, but is really getting pretty darn close. Or that's annoying. Let me exit out. Okay. Thanks. So, so she's got pre-diabetes, but kind of bordering, crossing over into type 2. She had people back home who were showing her how to harvest medicine, but she was talking to her clinical team saying, you know, it's really, our pharmacy team saying, you know, it's really hard to do this. I gotta drink this like 3 times a day, and I'm finding it difficult to do that. So I don't know if it's working or not, but I'm finding it a little bit hard. So she was being honest about that. And then the pharmacy team, you know, again, it was a newer pharmacist who didn't have much experience with Alaska Native people. This was one of the first things I learned when I came back to Seattle, just working at the Indian Health Board, because so many people from Alaska were using Devil's Club as a medicine for a variety of different reasons. But that's the plant that's shown here. And it's got a cute little berry top that looks a lot like Eastern ginseng too. So it's in that particular family. So it's got multiple uses. It lives from Oregon up into Alaska. And there is evidence that it lowers blood sugar, but it's not at the level of high-level randomized controlled trials for that. And my clinical experience with this is that the person who was doing that, actually, that's probably the target patient, someone who has early type 2 diabetes. You know, it's not type 1 people, because it doesn't have anything to do with with issues of like mimicking insulin, or it doesn't work like that. So so for her with pre-DM, yes. Early type 2, yes. Polycystic ovarian syndrome type folks, yes, that could be really effective. And most people really are using that medicine. Tastes great, but it comes as a tea form, but it's not one and done. You have to use it fairly consistently. But there are people who use it also topically. So the medicine is really coming either from the root system, or maybe coming from the stem bark, which is full of stickers. So any of you who've been hiking out in those territories, if you run into Devil's Club, you will know it because it will leave a little sticker residue behind for you. But there are people who also have specific spiritual uses, which is not the things that I question them about with that, but that people have shared in terms of just why in their communities they may choose to use those particular medicines. And then our last little review is a person who kind of in their 40s, who's been kind of stressed out. They've got family stuff going on. They have some back pain issues. They've been examined. It doesn't look like it's anything that's serious, what I would call a red flag kind of symptoms with it, but they still have it. And they saw one of our physician assistants, and the PA told them that they thought they were pretty stressed out and that they really needed to consider kind of like an anti-anxiety medicine, that maybe an SSRI. That patient was not having it, so they're like, I don't know if I want to go see that person. I don't feel like we were on the same page. So they were seen by one of our team again in follow-up, and the person was looking great. They were looking more upbeat and said that they felt like their back pain was actually kind of improved. And so again, just noting that, and then sometimes just the fact that you're acknowledging relationship, noticing, and they spontaneously told our colleague that, yeah, I went home. And there was someone at home who was making medicine, and I got it. And they call it Mad Dog. Ooh. So it's pretty hard when you have a English with an interesting term, or some of our indigenous language might be really specific for plants. And so I think around the world, a lot of us have used Latin. I was never trained as a botanist person. I'm not trained with Latin. And so if I've learned anything, it's just, I don't know, osmosis or something, but it's hard. But I realize when I'm trying to research things for people, I have to get to Latin so I can understand what's what across the world, because we have lots of nicknames no matter where we are. And so, but there's a picture of it, and I saw it in the garden today, doing quite well. So, something called skullcap or Scutellaria. So does that reduce? It's kind of in the mint family. It does indeed promote relaxation, kind of reduces the stress response. If people are calling it, I'm stressed out. I call it anxiety, whatever you're calling that. And at higher doses, depending on how you dose that, you could actually get somebody quite sedated. So time to go to sleep. But it could also reduce muscle spasm. But well, that makes sense. So there's actual activity. There's some smooth muscle activity and there's skeletal muscle activity with that. Like, that's interesting. So, and if you were, this person was like, hey, I'm gonna talk to the pharmacy team. Okay, cool, let's do that. What did you find out? Hey, Terry, guess what? It has reactivity with serotonin receptors and actually probably even a benzo receptor. Like, oh, maybe that's true. And it's not the same way that somebody who's taking whatever, like a Valium, it's not the same receptivity in terms of just people's affinity for that. But it says, hey, this is what we found out in terms of just like how people were doing some of the actual preparation for that. And it's pretty darn bitter if any of you have actually made your own, tea, or maybe if you like bitter, it's good. So for some folks, we may have to doctor it a little bit to be able to make it a little more palatable for them to be able to take that. And there's clearly cross-reactivity with other meds that cause central nervous system depression. So again, that's a conversation of, well, if you're on this, can we negotiate that we're not going to be on that, or lower doses of that, or monitor you for, for symptoms. And there's a very real reactivity for some of our plant relatives, depending on what your source is. So if you're growing your own or harvesting your own and you have good, good capabilities there, for safety, that's great. But there are plants that look like this, especially when it's in flower, because it's got a lovely flower. But if you're not able to make a positive ID, you may be taking something that we actually know to actually have more liver toxicity. In the case of this, it's something called American germander that can be in the same zone. So that's a thing. I put up here resources. You will have many resources available to you, especially if you're working in this domain. Some of them will come up with nothing. You'll go to NatMed and it says, don't know, not reported. So that's a real thing, which is where the community experience with the medicine might come in much more handy. So I do, a lot of our team uses the NatMed database a lot, just to be, and again, I think that's important because sometimes people want to know, what's my risk with with this? Can I really do that? Or who have different belief systems. For example, with black cohosh, saying, "Hey, I'm taking black cohosh, Terry, for for menopausal symptoms." Okay, and I'm taking it for my bones. So wait a minute, do you mean like osteoporosis? Do you mean to strengthen your bones? And there's no data for that. There's just no data for it that does that. And so that's a conversation too. It's just like, I know you are, if that's the primary, and if someone is really, osteopenic or osteoporotic, that's a different conversation going. That may not be our bang for the buck medicine. We may have to think of something else for you for that, because right now I'm not seeing that data, or I don't know what you want to do with that, but that's what I know about it. What do you think? Consumer Lab, I like that just in terms of some of the reviews have been really pretty terrific, very well documented in terms of what's in the literature especially for safety, elements, and rating specific products. So when someone asks you, hey, what should I get? I have to buy this commercially, what's a good product? You can actually name specific products that have better safety controls associated with it. I also like the American Botanical Council, primarily for the Herbal Media Watch, because it just you can't keep up with everything, but it's sometimes fun for me to just see what's going on in terms of indigenous plant medicine work that's being done around the country and around the world in terms of news that might be translatable to clinical practice. So I use that a lot. The resources that we use for Coast Salish communities for teaching the community members to reclaim our practices. And I'll show you those books for those of you able to come this afternoon. It's a lot more hands-on, tasting and eating things if you want. And so just these resources are books that I call it bibliotherapy for people to be able to give them, empower them to learn more, to be able to take care of themselves. So I just want you to think about how you do this. How could you weave this into your clinical care? And so part of it is the first thing I said, which was, despite gray hair, I will be learning, I hope, till the day I go. You got to stay humble. I don't know, but I'll try to find out for you. It may not be today, though. Like, I know you want an answer today, and I don't think I can answer that today. It's going to take a little time. Being respectfully curious with a specific, and linking it to why you feel like you may want to know in terms of keeping things safe for people. So, but again, I'm also looking for, when I'm working with people, what's the life cycle change? Someone that's a life cycle change of pregnancy, life cycle change that their health just took a serious dive, life cycle change that they're new in sobriety. So I'm looking for those changes because that's usually entry point for a lot of people, to get back into that. And I do want you to look at the Western science piece of it. I just want you to also tread smartly with this in terms of your interaction with people in the community. Find resources for them. Yes, we put them into after visit summaries so that people can take that home. Yes, we recommend specific spots if we know, just like, well, down in Tacoma, like there's only one place that people go to for, for some of the, if they have to buy commercially. We just tell people that, again, we don't have stock in it. It's just like, we just want you to know, because you're new to the area, this is where many people go to get this. And again, this partnership with our Indigenous knowledge holders and all of the 8 beautiful Native communities that are here, and again, around the country. So our conversation this afternoon is going to be examples of things that are from all over the country, because especially in an urban setting, people are coming from everywhere and are also very interested sometimes in other native plants that work, as well as non-Indigenous plants that work for them. So those partnerships, I think, are crucial. Jan, my daughter, reminds us of our original responsibilities. And the lack of respect to that natural world makes it go away. That doesn't mean you have to use plant medicine, but you have to be able to acknowledge that. So the walk through the beautiful plant garden, that acknowledgement is, I don't know some of you, but I'm glad you're here. You're here to help, you're helping some part of this natural world. So she says if we don't use them, we don't acknowledge them, it's gonna go away. And I wonder about that too, in terms of some of the challenges that our plants are having, in terms of people's disconnection from that world. That's all I got. So now let's say with Fuego, and we have a little bit of time, I think, if there's any comments or questions. So now again, for the invite to visit with all of you beautiful people, Nawakwa. And I'll turn it back over to Brittany.
Thank you, everyone. If does anybody have any questions real quick? Anything pressing at the top of your minds? I know there's one in the chat.
Oh, okay.
Answer that real quick.
Okay, so the first question is, thank you, Trent. What does coverage pharmaceutical interaction verification look like with herbalist prescription within the formulary? So what that looks like is our pharmacy team, either our clinicians are doing that or our pharmacy is actually doing that. From a prescription standpoint, at least the way that it's working within in Seattle, it's under a copay. So the copay would be for whatever, if they were getting amoxicillin, it might be the same copay if they're getting let's say an elderberry, type of syrup. If it's coming from the traditional health team, there's not a copay involved in that. The pharmacy team has nothing to do with that. That's really being done on a one-on-one basis with providing that medicine to them. So that's the verification that's occurring is the clinician doing that review and the pharmacy doing that review. When it goes to the traditional health team, they may be making a different decision. The second question is dosing in a tea. So I think in the case of that example that I gave, Trent, that's probably not how that's going to happen. So that milligram dosing would be someone who is purchasing that the skull cap commercially. So they're probably getting that typically like in a capsule type of form, as opposed to doing that in a tea. So that would be, of course, a pertinent question to the person who came, the guy who came in with his back pain and so the stress symptoms is, how are you using that? So when the herbalist, you bought that at home, what form, can I ask what form that was in? And so sometimes people are great when you show interest and respect. Just like, hey, you want to send me a screenshot? I'd be like, oh, Terry, I didn't bring that. But I will. Do you want me to take a picture of it? Yes. Or I have some labels that came in a box. I can drop it off. So when people trust you, they'll let you see that because they want you to be able to help other people too. So like they're trying to educate us. And that's a beautiful thing. So that's probably what it was, as opposed to the tea version of it.
All right. Well, thank you so much. And this is on behalf of the Native American Center of Excellence. I want to thank you for coming today. And let's again give her a round of applause.